Hello everyone. So today let's start with a case. A 35-year-old gentleman with no known comorbidities presented to the emergency with complaints of lower back pain for 2 months, urinary incontinence for 1 week, and lower limb weakness for 2 days. He reports no history of trauma or fever. On examination, his general condition was fair and his vitals were stable. On motor examination of the lumbosacral spine from L2 to S1, there was decreased power and reflexes of the lower limb. On palpation of the spine, there was tenderness over the L4-L5 region and his perianal sensation was impaired. Bulbocavernous reflex was absent and his anal tone was lax with absent anal wink. So what do you think this gentleman has? Yes, you're correct. It's Cauda Equina Syndrome. So let's start with what is Cauda Equina. Cauda Equina, which is the Latin for horse's tail because it resembles the tail of a horse, is a collection of nerve roots, L1 to S5 peripheral nerve roots, which originate from the spinal cord. And these nerve roots, they provide motor and sensory supply to the lower limb, to the bladder, to the perineum and to the anus. So these nerve roots, they are very sensitive to compression because they are just covered by the endoneurium. So the compression of these nerve roots result in something called the Cauda Equina Syndrome, which is basically a LMN lesion, lower motor neuron lesion. So this Cauda Equina Syndrome is a spinal emergency which is caused by the compression of these nerve roots. So these can be compressed by various causes. So we can broadly divide it into the compressive causes and non-compressive causes. So the most common cause for Cauda Equina Syndrome is lumbar disc herniation or prolapse of the intervertebral disc, PIVD. Other causes include lumbar spinal stenosis, epidural hematoma or spinal neoplasms. The non-compressive causes include spinal arachnoiditis or spinal infections. So how do these patients present? So as we already discussed in the case, they present with bladder or bowel dysfunction, saddle anesthesia. So it is basically the anesthesia of the region supplied by these nerve roots, S3, S4, S5. So it is called saddle anesthesia. Sexual dysfunction with or without neurological deficits of the lower limb. So this is basically considered the triad of Cauda Equina Syndrome. Other symptoms and signs include the lower back pain, absent or decreased bulbocavernous reflex, and absent or decreased anal wink. So bulbocavernous reflex is basically elicited by stimulating the man's penis, or in a female, her clitoris. So when we stimulate that, there is basically a contraction of the anal sphincter. So that means the bulbocavernous reflex is present. Anal wink is demonstrated by stimulating the anal region, anal sphincter, so that there is contraction of the anal sphincter. So this is also absent or decreased in cases of Cauda Equina Syndrome. So Cauda Equina Syndrome can be classified into complete or incomplete Cauda Equina Syndrome depending upon the presence or absence of urinary retention. So if the patient has total damage of the Cauda Equina nerve roots, then that results in urinary retention, which is complete Cauda Equina Syndrome. And if the patient presents with urinary incontinence or just straining during urination, then that means the patient has partial damage to the Cauda Equina nerve roots, so that results in incomplete Cauda Equina Syndrome. The diagnosis for Cauda Equina Syndrome is basically clinical, but it can be supported by imaging modalities. So we usually perform urgent MRI of the lumbosacral spine if the facilities are available, and if the patient is contraindicated to MRI, or if MRI is not available, then we can go with the CT myelography, that is CT of the spinal cord. And since Cauda Equina Syndrome is a emergency, spinal emergency, because as longer the nerve roots are compressed, the more worse the outcome. So we need to perform an emergency surgical decompression as soon as possible. So various guidelines suggest various time frames, time window for this surgical decompression. Some suggest 24 hours, some suggest 48 hours, but basically we need to perform the surgical decompression as soon as possible as it is diagnosed. So there are two techniques for emergency surgical decompression, the open decompression and the minimally invasive techniques. So in open decompression, we can go for laminectomy, hemilaminectomy, discectomy, depending upon the site of the lesion, the cause of the Cauda Equina Syndrome. And now as the technologies have evolved, there are minimally invasive techniques like percutaneous endoscopic discectomy, PELD, percutaneous endoscopic lumbar discectomy. So this technique can be done just under local anesthesia. So these are the two available techniques for emergency surgical decompression. If the patient has spinal infection, then we need to give antibiotics as well. So the treatment depends upon the cause of the Cauda Equina Syndrome. Now talking about the outcome, it is quite variable. Some patients they have significant recovery, especially those with incomplete Cauda Equina Syndrome or those who underwent emergency surgical decompression as soon as possible. They have significant recovery. And some patients, especially those who have complete Cauda Equina Syndrome or those who were diagnosed late and operated late, they are left with the residual dysfunction like the urinary and sexual dysfunction. So this is about the outcome of the Cauda Equina Syndrome. This is it about Cauda Equina Syndrome in brief. So this is a rare spinal emergency which is much more to be studied and much more to be researched. So I hope you gained something from this video, and I hope to see you in the next video. Thank you so much for watching.